Thanks very much, Joe, and thanks to Dr. Leitzman and Griep for inviting me to this great meeting, well attended, I see. These are my disclosures. So we've already seen in the last few presentations some talking about the natural history, which I don't think is really well defined. We do know these are rare aneurysms, and they're also aneurysms that are usually in conjunction with either proximal extent in the ascending aorta or proximal descending thoracic aortic aneurysms. One of the things we do know, and as we've seen in the last couple of presentations, is the morbidity and mortality can be high in some series. I think that if you're like some surgeons who've told me that their perioperative risk is less than 5%, this talk may not be for you. But before I get to some of these revolutionary techniques, you can maybe think about how you would like to treat this patient. This is a patient that we're going to be treating in about a month, who is an 80-year-old, pretty fit gentleman who had obviously a previous sternal split for a coronary artery bypass graft, and he has developed this very large aneurysm, which they've been following for the last 2 years, but he's a pretty fit guy, and now it's time to repair him. And you can think about how you would try to repair this with a total endovascular reconstruction. So what are the challenges facing us with these complex endovascular repairs? We know the arch is not like the infrarenal aorta. We know it's not like the thoracic aorta. It has fairly complex spatial geometry that you have to be concerned about. And one of the biggest problems is how do you get apposition? And one of the things I saw in the last presentation is it's very difficult to get apposition on the inner curve of the arch. That, along with the great dynamic strain that you see in the ascending aorta, along with the curved configuration of the arch as well as the graft and the high pulsatile blood flow, can also lead us to some concerns about the mid-term to long-term stability of these grafts. Well, up until the last year or two, this was sort of the minimally invasive way of treating these kinds of aneurysms, and I would hardly say that these are minimally invasive. These were usually reserved for high-risk patients, and a lot of them didn't do very well. The techniques that I'm going to be speaking about are fairly new, but this whole concept has been around for quite some time. 1999, Inouye was talking about these kinds of grafts. Back in 2003, Chuter actually pioneered a technique where we used to put these grafts through a conduit on the innominate artery or the carotid artery, and we'd actually put in a bifurcated graft from the neck and then come from below and catheterize the contralateral limb or the aortic limb and extend it with another stent graft. The problem with this procedure is it also had in conjunction extra anatomic bypasses with the carotid and carotid subclavian bypasses, and it was associated with a fairly significant risk of stroke. So I'd like to touch upon some of the, before I get to the branch graft stuff that I want to speak to you about. We had such good success with the juxtarenal aorta, with the fenestrated grafts, so we thought, why not use this technique in the arch? And we thought that preloaded catheter and wire would help us maintain alignment, because you're always worried when you put up these fenestrated or scallop grafts whether you're going to get alignment with the supraaortic vessels. And it seemed like an elegant procedure at the time when we were starting to do these cases. You just come from the right side, you snare the preloaded wire. Now you have a through and through wire, almost like a floss, and as you're deploying and maintaining tension on that through and through wire, that maintains alignment of the scallop, you deploy the graft, and there's what the completion angiogram looks like: good filling of the innominate and the extra anatomic bypasses and exclusion of the aneurysm sac. You can also use fenestrations for the carotid, and the advantage of that is you can actually stent the fenestrations and maintain alignment that way. But the big problem I saw with these techniques, and certainly I've been disappointed with the last two that I've proctored in other parts of Canada, because they've actually resulted in strokes, is I think this preloaded catheter and wire rubbing across the either the innominate or the left carotid is a source of embolic disease that we really can't control, and that's one of the reasons I don't like this technique. This last presentation by Dr. Yokoi has made me wonder if we really need that preloaded catheter wire for alignment. So here's what I really want to speak to you about is the branched technique. And again, we had such success with the thoracoabdominal branch grafts that Roy will speak to you about tomorrow. But with this, the principles are fairly straightforward. You deploy the branch graft, you come from the right arm, catheterize the branch and extend from the branch into the innominate artery. On the left side, you have a carotid subclavian bypass, which you access from the left arm, go up the carotid subclavian bypass, down the left carotid, and catheterize the branch for the carotid, and then extend this with a covered stent. Of course, this takes fairly sophisticated planning because 50% of this procedure really is the planning and constructing the graft, I think. And we have a Terra Recon workstation in our hospital, actually in my office, and the people who are constructing these grafts from Cook Medical base all their imaging and their graft plans on the Terra Recon images. And this is what they come up with, is a stent graft plan with the proximal and distal diameters as well as the branches coming off. Here we see the branch graft with being deployed but constrained by diameter reducing ties. I'll go into a little bit more detail later. So how do we make sure that those branches end up on the greater curve of the aorta? That's obviously what we're most worried about. Well, in the models, that greater curve, the branches always ended up mainly because of this pre-curved nitinol cannula. And no matter how hard you try not to put the branches to the greater curve, they always end up in the greater curve when they make the traverse across the arch. And this has been the case in all the patients who've had received this kind of graft as well. So the inner nitinol cannula seems to work. And again, the last presentation has made me wonder if we really need that preloaded wire in the fenestrated scallop grafts. So this is what the custom-made branch graft looks like. Here we have external openings. This is not the actual branch. The branch is actually proximal to this external opening and is situated here for this branch and here for this branch. And this is what it looks like if you were actually in the graft lumen. There's a series of trigger wires that belong to the diameter reducing ties, belong to the bottom and the top of the graft as well. So what does the placement of the device consist of? As I said, we like to do it in 2 stages. We like to stage the left carotid subclavian bypass. Then we bring the patient back. I'm not sure what the golden time is to bring the patient back. We've been usually working at 3 to 4 weeks. Then we can go transfemoral insertion of the stent graft, positioning of the device. I think deployment of rapid pacing is essential. And then we cannulate the branches from above access, as I described, and bridge into the target arteries. Here we are with the detail. We're going up with the graft into a fairly significantly tortuous arch. Again, here's the branches well laid out by the gold markers, a series of 4 the distal extent, a series of 2 markers on the proximal extent. And here, if we look at the image on the right side, we see the actual Lunderquist wire is buried deep into the ventricle. You need to do that in order to get this proximal. You have to make sure, obviously, your proximal stent is just distal to the coronary arteries and that the markers denoting your branches are actually underneath the supraortic vessels. But first 2 or 3 patients that we did with this, I was quite shy about deploying the graft too close, and I ended up deploying a little bit more proximally than I had to, which had no problem, but it proved to be a little difficult catheterizing the actual branches. Now I'm a little bit more liberal. I try to deploy these openings of the branch directly underneath the supraortic vessels. So here we are, we've deployed the graft, now we're coming from the right side, catheterizing the innominate branch, and we're going to extend into the innominate artery on the left side. We've come through the carotid subclavian bypass down the carotid with a wire, and we've deployed a covered stent from the branch into the left carotid artery, and there's the completion angiogram that you see on the right. So what are the anatomical criteria that we use? I echo Joe's sentiment about the ascending aorta. You really can't put these into any aortas that are bigger than 38 millimeters in the ascending aorta. We like for the target arteries to be a 20 millimeter landing zone preferentially. Obviously, we like to avoid calcified aortas because of the risk of stroke. Diameter of iliac arteries are important. These are huge French sizes, 24 French, and sometimes I put them actually, if the external iliacs are too small, I'll just put them directly through a purse string in the common iliac arteries for access. So in our initial experience, we have 6 patients. Again, the risk factors are there. I'm not going to go into too much detail, except to say that 5 out of the 6 were ASA greater than or equal to 4. Here's a kind of a review of all. We had 4 out of the 6 were completely successful. The very first case, I'll go into some detail, had a type 1A endoleak, which we fixed. And the fourth case, I'll go into a little bit more detail as well. It ended up with a stroke, but fully recovered. So this was the first case that we saw. This is a good lesson that you can't just base your treatment plan on or judge a book by its cover. You can't base it on coronal images only. You have to look at the sagittal as well as the 3D reconstructions. This was not a patient appropriate to try to get a seal up in this area, and we felt he was appropriate for a branch graft. So this was the first branch graft done of its kind, and so it was a kind of a prototype. And as you can see, it had very different branches than what I've described to you. It had actually external branches, which we thought was a good idea because we thought the funnel-shaped branches would facilitate catheterization from the supraaortic vessels. It did have the inner nitinol, pre-curved inner nitinol cannula, which would help with the arch, but it didn't have some of the other features that I'm going to describe that the newer generation does. So this was the first case. We had a good technical result, but post-op we had a type 1 endoleak. It took a little while to figure out where it was coming from, but we were able to see that it's from the proximal stent not having great apposition to the inner curve of the proximal ascending aorta. So I was able to fix that by coming retrograde from the distal end of the stent, coming retrograde into the sac and just coiling the sac. So because of that first case, we made some modifications, which we see in the current generation of devices. We've changed from these funnel-shaped branches to the openings, diamond-shaped openings, and the internal branches that I described earlier. We've changed the proximal stent to those of you who are familiar with the Proform technology with Cook. The first Proform, the Proform technology with the first stent really helps avoid some of these bird's beak phenomena that you see with the inner curve of the ascending aorta. The other thing that I like about what they've done with the modifications is often these cases need to be extended with a second stent graft into the proximal descending thoracic aorta. The last thing you want to do is remove the proximal delivery system and leave this stent graft so that the second piece comes up and sometimes pushes this whole stent graft forward and ruins all your work. So I like the idea of doing this. What they do, we leave that last trigger wire attached so we actually maintain control of the proximal device, and then we use the contralateral access to come up and go up with our second device for deployment for a proper, adequate seal between the two junctions here. Our second case, again, transverse arch aneurysm went very well. Here's the completion CT that I think Joe showed in one of his slides. We felt we were so experienced after 2 cases that we would start to really fiddle around with the procedure. This was the 3rd case we did, and this is a good example of really thinking too hard and trying to make a good operation better. It's sometimes not a good idea. And what we thought is we started to try to predict the path of the supraaortic catheterizations from the supraaortic vessels into the branches. And what we came up with in this particular case, instead of the conventional alignment of the branches, we thought it would be better if we changed the alignment and put the proximal branch distally and vice versa here. And this is what happened. On the CT, technically we had a good result, but on the postoperative CT, on postoperative day 2, you could see compression of the carotid branch, and then in hindsight, it's not surprising why, because we reversed those branches. This was remedied no problem with a balloon expandable stent, and this patient has done fine. You always have 1 or 2 cases that you wish you could have back. This is one of them. I don't think any of us really knows what the natural history of a saccular aneurysm coming off the innominate artery is, or the appropriate threshold of repair. But we decided that this would be a patient that we would do, and during that last 3rd case, this one was being planned, and again we thought a bit too hard about predicting the cannulation path from the supraaortic vessels, and this proved to be a real problem in this particular patient. And you can see, in hindsight, it's very easy to see why we wouldn't have saw that it would be difficult to come from the innominate artery and get into this particular branch over here. And it proved to be impossible, actually, after a few hours of trying, and we ended up having to do an extra anatomical bypass just to perfuse his carotid, and he ended up with a stroke, which he fully recovered after 2 weeks. It's now 6 months, he's clinically well, and we've shied away from trying to go after that aneurysm. He still has a very late filling endoleak, but we can only assume that it's a late filling from the proximal branch. The fifth and sixth cases here went very well without a hitch. Joe Bavaria came up for the fifth case, I believe. Technical considerations that have come out with this experience. We know that anomalous arch anatomy can be challenging, but we think the branches actually deal with that quite well, as opposed to some of the fenestration combinations. I don't think we're quite ready to be treating aortic dissections with this technology, as the experience worldwide is still limited. I write here, the rotation of the device in the arch is not advised. It's not only not advised, it's almost impossible to rotate the device. So that's why the pre-curved nitinol cannula is so important for determining the greater curve alignment of these branches. The status of the aortic valve is important. Obviously, you can't put this through significantly diseased valves. I put the rapid pacing techniques as essential. I wouldn't let, if you're going to try these procedures, you shouldn't let anybody convince you that adenosine or hypotension is appropriate for these kinds of cases. I think they all should be rapidly paced during the deployment. We're not seeing the injuries to the left ventricle that we saw with some of the previous Tudor devices and the devices beforehand. I'm not sure why. I suspect it's because Cook has concentrated the experience in only a few centers' hands for now. We haven't seen much retrograde dissection, but we're still troubled by the possibility, and certainly what we've seen with the risk of stroke, and that could prove to be the Achilles heel of this procedure. The method may not be applicable to everybody. Obviously, aneurysms of the arch involve in the ascending thoracic aorta, as well as patients with extreme tortuosity, although I think we're going to put that to the test with Dr. Moon in Winnipeg next week. Any patients with extensive atheromatous involvement of the aortic arch obviously is a contraindication as well. And as well a prosthetic metallic valve. You're not going to be able to put a delivery system through that. So which brings us back finally to that case that I showed at the beginning of this talk about what you would do for a case like this. What I was trying to get at is, what do you do about these coronary arteries, which are actually close to your landing zone? And this is what we've come up with. Here we go with a conventional, or what we think is conventional branch graft for the arch, but also, as you can see, we've made a scallop here, which hopefully will incorporate the coronary artery bypass. This is the graft that's about to be loaded into the sheath, and then the sterilizer. And if you invite me back next year, I'll tell you the results of that procedure. So in conclusion, we don't know the long-term durability, and I can tell you that we're now 18 to 24 months out with a couple of these patients, and they've done fine. My gut feeling is that if you get past the 30-day mark, they're going to be much like some of our fenestrated and branch graft experiences. They do fine long-term. It's really going to be the choosing the right patients to get the right technical result that is going to be the determining factor. We think right now we've shown that the method is relatively safe in experienced hands, as I said, but we'll wait to see what the mid to long-term results are in the next few years. Thanks very much. I appreciate it.